Good evening and a warm welcome to all. At the onset, I wish to thank Kollam Ophthalmic Association, Dr. Rajiv sir, President Dr. Mini, and Secretary Dr. Shaini, and Sipla for the opportunity. Let me just share my screen. My topic is a practical approach to medical management of glaucoma with updates on recent advances. In the next few slides, I shall be outlining the principles underlying medical management of glaucoma via case-based approach, a brief summary of the anti-glaucoma medications, with just a few salient practical points on the existing drugs and updates on the new arrivals. This is a favorite graph of mine, which is recommended by the European Glaucoma Society, which depicts the decay of the retinal ganglion cells on the y-axis, gradually leading to blindness, and the x-axis represents the age at disease onset. As you can see, the hashed line A, it represents the natural aging process, the physiological decay of the retinal ganglion cells. Lines D and E have the same age at onset, but you can see that the D never attains a severe visual impairment, while E has a significant visual impairment at a reasonably early age, which means that line E represents a rapid progressor and line D represents a slow progressor. We have to identify the rapid progressors so that you can aggressively treat them and closely monitor them so that they do not cross the zone of severe functional impairment. The graphs B and C have similar slopes and hence similar rates of progression, but C starts at an early age and does cross the zone of severe visual impairment, rather functional impairment, and B doesn't. So C also needs assessment of risk factors and a lower target IOP compared to B, which can probably be observed because of the late onset and early disease or early glaucomatous damage. So the age at disease onset, the laterality, that is bilateral disease, and disease severity are three major factors which have to be given weightage in the proper management of a case of glaucoma. We know that even though glaucoma is, there's a lot of awareness about glaucoma, but a considerable percentage of patients have severe bilateral functional impairment in their lifetime. We know that clinical care should always be guided by evidence. And that is why this slide I have depicted all the landmark major RCTs, the OATS, the normal tension glaucoma study, the early manifest glaucoma trial, the UK prevention studies, and then later the EAGLE and the LIGHT trials, LIGHT and ZAP trials, with the years of publication of results. This patient of mine came to me in June 2020 during COVID times, with actually presented with a subconjunctival hemorrhage in the right eye, but on evaluation, I noted a subtle inferior notch in the left eye and occludable angles. So I advised YAG laser iridotomy, which was difficult for him to accept, but still he reported early enough for me to do a laser iridotomy, and hence on a single medication in his left eye, he retains the same visual field and the same degree of inferior sectoral aeronefal damage in his left eye that he presented with. So the pearl here is that you have to establish a diagnosis, not just diagnose glaucoma with a comprehensive ophthalmic evaluation, but you have to diagnose correctly the type of disease, whether it is an open angle or an angle closure. And the key tool for that is gonioscopy. The art of gonioscopy has to be mastered by a clinician for a good management of glaucoma. All of us see a lot of patients who come to us either referred or come to us on their own on medications which they do not reveal to us because they have come for a second opinion. And very many times by our clinical experience, we get hints that they are medicated and we try to extract their documents. So one important finding which should be there in most of the referrals, I would say, is that it's best that the clinician mentions the baseline intraocular pressure with the tonometer used, because it is useful for the doctor who's going to be handling the patient next. This lady, she had seen a local ophthalmologist on 19th May and had an IOP of 31.8 with the shorts. And after receiving both systemic and topical medications, when reviewed locally there again on 10/6/2022, she's noted to have a lower intraocular pressure. So when she came to me, I knew that her pressures were normal now, borderline now on medications. And since her angle showed, since her diagnosis was for plateau iris, it was lasered and she's doing fine and expected for a follow-up next week. Similarly, another patient actually on medication betaxolol since 1993 was using it erratically initially and then presented on 6 months of therapy in 2015 at Alapi Medical Center. And all this she had not revealed to me. She came to me, got her pressure checked, wanted to take a second opinion on glaucoma, and I found pressures of 16, and I was wondering why she's on medication because my diagnosis was physiological cupping. Later, I got extracted this data from her, and then she came out with a document which showed that despite treatment with pitaxolol for 6 months on a continuous basis, her pressures were on the higher side. Since the pressures are now 16 on the same medication, two outcomes can be thought of. Either we are dealing with an ocular hypertension which does not need treatment at all, or we are dealing with an ocular hypertension which is highly showing fluctuating intraocular pressures. So the pearl here is that, just as mentioned in the OAT study, in patients with ocular hypertension, patients with glaucoma suspects, and patients with NTG, it is mandatory to do a central corneal thickness. And central corneal thickness is not a single value. It just means that you can divide the patients into normal thickness, thin cornea, or thick cornea, and it is the thin cornea which has a risk of progression. So factors influencing the clinical management in glaucoma, apart from the two mentioned here, the others being risk factors, especially the family history and the structural functional correlation of the damage and function, life expectancy of the patient, and systemic comorbidities that the patient has. All these influence the management protocol. The next patient also has large cups, but it's a middle-aged patient and he is an uncontrolled hypertensive and he has got pathological cupping. So, as evidenced by the advanced fields on the advanced tubular fields with fixations paired, but which is stable over the years till last seen in 2017, which means why is it so well controlled? That's because, again, the EG has proposed this tabular depiction of target intraocular pressure, which says that if you have advanced disease with risk factors, it's better to target a low intraocular pressure, and that's exactly what was done to this patient. So various studies recommend 20%, 30%, or 40%. So the target IOP range is between 20 to 40%. Again, target IOP is not a magical number. It is a range. And every patient, when we start treatment, we should have in mind a target intraocular pressure, which is dependent on so many factors like patient preferences and various other factors as mentioned here. But I would like to highlight the status of the other eye, because if the other eye, if the patient is a one-eyed, then definitely even if there are fewer risk factors, the suspicious eye has to have a lower target. This is the fourth case, an asymmetric POAG. POAG, as we all know, is a disease of exclusion, and the asymmetry is well evidenced by the between the two eyes. Again, this was shown to realize that you have to individualize target intraocular pressure. Either eye has to have a separate target, and you have to prescribe treatment accordingly and evaluate progression if the patient is stable or progressing. If it is progressing, you have to aim for a lower target. And even if you're following up a stable case, whenever it becomes progresses again, you have to further redo and have another target, a revised target intraocular pressure. So re-evaluation and reassessment during the course of the lifetime should be done as the patient is followed up. These are the Humphrey GPAs, and on the left side showing the stable glaucoma. On the right side, as you can see, from 2010 to 2017, you have a likely progression in glaucoma as evidenced by the increased numbers of the full-fill triangles here seen. The next case again is an asymmetric GON, but it's rather a unilateral GON with the right eye more of a normal eye. So she was a unilateral NTG. I started treatment for her in 2018 after a DVT and she was following up with reasonably normal, very normal intraocular pressures and a 30% reduction of IOP till I found a subtle progression in the superior arcuate scotoma. So then I looked into the disc and there I see bilateral splinter hemorrhages. So whenever you have a progression, you have to think of the risk factors for progression and manage the case. Now this patient, I had even excluded, done a sleep study as well as a carotid Doppler, but she was progressing despite normal, everything was normal, but still the patient was having progression in fields. And a revision gonioscopy showed that the patient was moving on from an open angles earlier on in 2018 to a intermittent closure because of plateau iris. And so she was lasered, after which she's been stable. Follow-up ocular hypertensives, you have to stratify into low risk and high risk and re-evaluate the low risk 12 to 24 months intervals, the high risk at 6 to 12 months intervals, and consider treatment when indicated. A POAG suspect, you can re-evaluate 6 to 12 monthly. And an established POAG, you have to establish the target intraocular pressure. And if stable, re-evaluate again 6 to 12 months period. But if progressing, you have to reconsider or revise target IOP, get a new baseline, and then evaluate again every 6 months. Gonioscopy, whenever there's a change, whenever there's a progression, to rule out an angle closure element is a must. Thanks to the wide array of anti-glaucoma medications over the past 50 years that we have, medical management is the first line of management for most adult glaucomas now. Way back in 1875, pilocarpine was there, then came the timolol, and then the carbonic anhydrase inhibitors. Epinephrine is no more there. Latanoprost came up in 96, followed by the carbonic anhydrase inhibitors, brinzolamide, travoprost, and bimatoprost came up in 2006, tafluprost in 2008, and finally the ROCK inhibitors came up in 2018. So which drug to choose? That again, you have to weigh between the patient characteristics and properties of the drug. Whatever it is, you have to keep in mind the quality of life of the patient and affordability or cost factor of the patient when you take a choice on the first drug. What are the drugs? what is the mechanism of action of the anti-glaucoma medications? We have drugs which decrease the aqueous humor production, like the alpha-2 agonists, the beta-1 blockers, and the carbonic anhydrase inhibitors, and drugs which increase the outflow, the uveoscleral outflow will be increased by the prostaglandins, prostamides, and the alpha-2 agonists. The cholinergics increase the trabecular outflow. Then what is different in the new arrivals, the new drugs? They actually increase the conventional outflow pathway by decreasing the trabecular meshwork resistance and also decrease the episcleral venous pressure. One should know to what extent there is a reduction in IOP with a particular class of group of anti-glaucoma medication. And you can see that the oral carbonic anhydrase inhibitors have the maximum about 40% reduction, followed by the prostaglandin analogs over 20 to 35%. Other classes have almost similar percentage reductions. The algorithm is start with a unilateral drug, drug in one eye and monotherapy, and look for the percentage reduction from baseline and tolerability. A lot of whether to go for a unilateral trial, it just depends on the clinician, but the CGIG always, the Southeast Asian Glaucoma Guidelines actually proposes still the unilateral drug trial. If it is not tolerated, but it is effective on IOP, and the target IOP is reached, then you just have to keep following up. But if the target IOP is not reached, you have to add the second drug or consider alternative therapies. Suppose the medicine is not effective, then definitely you have to go for a switch or go for alternative treatment modes. After the second drug addition, again, if the target of IOP is not reached, but the drug is effective, then you can go for a third drug, or you can go for alternatives like surgery or incisional surgery or laser. But if the target IOP is not reached and the second drug is not effective, then you have to substitute that drug. This is an algorithm which is useful. And the washout period of the topical drugs have to be known, because only then you will know when you have to call back the patient after you have discontinued a particular medication. And the least washout period is for pilocarpine, it's just 1 to 3 days, followed by the topical and systemic carbonic anhydrase inhibitors about 1 week. When you start oral carbonic anhydrase inhibitors, you can call back after 72 hours. Prostaglandins have the longest, 4 to 6 weeks, and beta blockers very commonly used previously. You should understand that it has a reasonably long washout period of 2 to 5 weeks. So coming to the drugs in each, it's known to all of us of that. Most of them and the lower dose strengths are available for the bimatoprost now. Only tafluprost is not easily available here in our area. Otherwise, the others are all available. And most of the local effects are known to many. It's conjunctival hyperemia and periocular pigmentation, periocular fat atrophy, and hence the prostaglandin associated periorbitopathy and the hypertrichosis, as well as the lengthening of lashes. So it is contraindicated when you have uveitis, when you have CME, and in a case of reactivation of herpetic keratitis. Usually there's not much of systemic issues, but I have had experience having had to discontinue it on the recommendation of clinicians from the critical care for respiratory failure, which is not getting adequately managed. And hence I've had to replace them, and they have given me the feedback that patient has improved significantly on discontinuation. So whether bronchial asthma is a relative systemic contraindication is to be thought of. And beta blockers, the ones are the timolol 0.5 and the long acting, and betaxolol, which is cardioselective. And local effects are known to all of us, apart from the local SPKs and burning, etc. Corneal anesthesia, but systemic is what is important, because one cannot start beta blockers when you have cardiac arrhythmias or when you have complete heart blocks or second degree heart blocks or sinus bradycardia. Carbonic anhydrase inhibitors, again, the acetazolamide, the systemic can have systemic side effects. The topical ones do not really have much of systemic side effects. They have more of ocular side effects related to allergy and burning, stinging, and local issues. Even a metallic taste in the mouth. So you have to ask for sulfur allergy before starting the oral acetazolamide. And also, it is relatively contraindicated in people with G6PD deficiency, which is quite common amongst the Maldivians who keep visiting us. So we should know that it may not be a safe drug to start in such people because of the risk of hemolytic crisis. Alpha-2 agonist, again, apraclonidine is not available now, but brimonidine, it's more, it has some more of these local allergic effects, immediate allergy as well as delayed allergic effects. And contraindications, it probably cannot be given with the monoamine oxidase inhibitors. And it is relatively contraindicated in the young, below 6 years, because of risks of apnea as the drug crosses the blood-brain barrier. So systemic, I would say that a good number of patients have had to stop because of induction of drowsiness and fatigue. And so one of the things you can tell the patients to do when you give an alpha-adrenergic agonist is to occlude the punctum, because this NLD occlusions helps. Pilocarpine is not really used now. It's probably reserved only for pre-laser iridotomy as or plateau iris. Hyperosmotics again are used in the acute management of glaucoma, and one should not give mannitol when the patient has a cardiac or a renal failure. So which drug to choose will depend upon the systemic contraindications and ocular characteristics. When you have a bad ocular surface, you can consider the preservative-free options. When you have concomitant systemic contraindications, you can think of prostaglandins. This picture shows you the follicular conjunctivitis, which I told you about brimonidine, the conjunctival hyperemia associated with the prostaglandins, and the limbal hypertrophy, allergy, and eczematous dermatitis can very well occur with the topical carbonic anhydrase inhibitors. It's very messy. Once you have it, that takes a long time to go. And you may sometimes need the help of a dermatologist as well. Periocular hyperpigmentation, sunken orbit because of the fatty trophy, the prostaglandin-induced periorbitopathy, and the hypertrichosis is what is shown in these pictures. So in general, I have discussed most of them. When you have concurrent systemic beta blocker use for hypertension, it is better to avoid the topical because you may not get the desired effect. Other things I have discussed already. The poor corneal endotheliums, it's better to avoid the carbonic anhydrase inhibitors. Then when you don't get the expected response with the prostaglandin analog, you can actually switch to another prostaglandin from the same, another drug from the same group. Sometimes it works. Even when you have hyperpigmentation or hypertrichosis with one, or hyperemia excessive with one, you can try for a switch and it does work out. Pregnancy, lactation, and medications, anti-glaucoma medications. It's a very controversial topic. To tell you the truth, actually, nothing is safe. So when a patient, before pregnancy, one is planning a pregnancy and has glaucoma, it does matter because the EGS again says that if you have early glaucoma, you can go for an SLT. Moderate glaucoma, you can go for traps. You can go for the filtration surgery and you're safer, because no drugs are absolutely safe, especially in the first trimester. Even the systemic carbonic anhydrase is contraindicated because of the chance of teratogenicity and limb malformations, etc. The IOP comes down in the mid trimesters, and so you can actually, if you can decrease the medications and observe IOP also, it's fine in the early glaucomas and not the advanced variety. So prostaglandins are otherwise safe except in the last trimester at the time of labor, and The brimonidine is not safe in labor as well as immediate post-op because of the risk of apnea to the fetus, to the infant, the neonate. So during pregnancy lactation, probably the pilocarpine and the carbonic anhydrase inhibitors, the beta blockers and carbonic anhydrase inhibitors are probably safe. Prostaglandins 2 may be safe during breastfeeding. A few practical tips. Once you apply a drop in the cul-de-sac, within 5 minutes, spontaneous tear flow washes out the drug. So between two installations, the recommended minimum interval is 2 minutes. Squeezing or blinking influences washout. NLD occlusion has to be taught to the patients. Why? Not for greater efficacy of the drug, but to reduce the side effects. So ask a bystander to put the drops, 1 drop in the cul-de-sac, and then tell the patient to use the index finger and apply pressure at the site of the NLD without squeezing one's lids. You can keep the lid open. Suspensions you have to shake before use. Now there are a lot of generic drugs versus the brand name drugs. And we know that the two share, everything is common between the two, the generic drugs and the branded drugs. The active ingredient may be almost the same, extent and composition may be the same, but issues are always with the adjuvants. So the osmolarity, the pH, the viscosity, everything changes. And even the drop, it has to be a standardized and FDA approved bottle, because the size of the bottle, the size of the bottle tip, all this affects the extent of drug administered into the cul-de-sac. There is not much of evidence to support the dietary cannabinoids and dietary supplementations, and alternative therapies like yoga really help glaucoma progression. Neuroprotection also, there's not much of evidence to support the use except for ginkgo biloba, acetylcholine. The neuroprotectors may be either glutamate antagonists or calcium channel blockers or antioxidants, and nitric oxide synthetase inhibitors, because you know these nitric oxide synthetases are present in the Schlemm's canal, trabecular meshwork, and ciliary muscle. So when you have inhibitors, then the free radicals, etc., extent will decrease, and hence so you can prevent apoptosis. What's new? The ripacidal, the metacidal, and the preservative-free drugs are what is new for in use now. Drugs which have novel targets are the ROCK inhibitors, the nitric oxide donors, the adenosine receptor agonists, the gene therapy, stem cell therapy, and neuroprotectors. Then you have the drug delivery new systems like either ocular inserts, intraocular implants, injectables, punctal plugs, and nanotechnology, newer preservatives, all of which I shall be discussing subsequently. The ROCK inhibitors, the commercially available ones are ripacidal and metacidal. Facidal has been tried in a few cases of advanced glaucoma and is found to have promising results. How do they act? The ROCK inhibitors, they are inactive. They are G peptides which are inactive in the guanosine diphosphate form, and once they are in the guanosine triphosphate forms, they are active. And the active isoforms A and B, they actually increase the space between the endothelial cells of the Schlemm's canal, and so the trabecular meshwork looks more porous, becomes more porous and more permeable, and hence improving their outflow capacity. They also inhibit the enzyme at this level, and hence they will act at the cytoskeletal level of the trabecular meshwork, and you have a decreased actin polymerization and hence smooth muscle relaxation in the trabecular meshwork, resulting to decreased resistance and increased aqueous outflow. These are the two hypotheses regarding the mechanism of action. The ripacidal was the first to be launched. It was launched in Japan in 2014 and at a concentration of 0.4% BD dosage. And the adverse effects being conjunctival hyperemia to the extent of 76%, with blepharitis and allergic conjunctivitis approximately 20%. These are all the major randomized controlled trials of the ROCK inhibitors. The first one, the first study, 7-day study, which showed that this particular drug, the ROCK inhibitors, are capable of reducing the intraocular pressure. And the other studies were mainly done by Tanihara et al., which I'll be showing on the next slide. These Tanihara et al. Slides. The first one showed that the BD dosage is adequate or optimal. The second is a study, 1-year study on 388 patients where they have four cohorts, one ripasidil alone, next is ripasidil along with latanoprost, third ripasidil along with beta blocker, and fourth a fixed combination of all the three. And it was found that the change at peak was 3.7 and IOP reduction at trough was 2.6. So that was the reduction encountered, and the lowering effect was acceptable as a monotherapy agent or as an additive therapy. Regarding additive therapy, you have these two trials, ripasidil with timolol and ripasidil with latanoprost, and it was found as an additive drug. IOP lowering effect occurred at both peak and trough with the timolol when combined with timolol, and when combined with latanoprost, the additive lowering effect was more at the peak. This is the 4 cohorts that I talked of: the higher peak, reduction at peak, and the lower reduction at trough. A post-marketing surveillance by Tanihara et al. Of ROCK-J, which found that at the end of 3 months, 8% adverse effects were noted in the patients who were on ripasidil. And what is interesting to note is that at different pressures, ranging from 15 to 35, there was an IOP lowering effect, which means that ripasidil can probably be used in those patients with NTG as well. Natasidil is the next ROCK inhibitor, which got FDA approval in 2017 and is available as a once daily use because it has a longer half-life of 12 to 17 hours. The concentration is 0.02%. And compared to ripasidil, it has got a lower degree of hyperemia, 47%. And the combination of the two with prostaglandin analog has adverse effect, has hyperemia levels of 58.7%, which is lesser than the additive effects of each of them separately added together. So conjunctival hyperemia is a major concern, then pain, local pain at the site of installation, and subpetechial hemorrhages close to limbus, which may be seen with natasidil in 14.5% patients, and cornea verticillata, which may be seen in patients with natasidil in 11.6%. How does it act? It acts on the trabecular meshwork by relaxing it and increasing the outflow. Apart from that, because it can inhibit the norepinephrine transportase, it can decrease aqueous humor production by inhibiting the sodium potassium ATPase in the ciliary body, and hence you have decreased aqueous humor production. Also, it lowers episcleral venous pressure. So it has a triple mechanism, and hence you can expect a lower reduction of pressure. And the studies with natasidil are the ROCKET studies, the ROCKET 1 and ROCKET 2. The ROCKET 1 showed that 0.02% was found to be effective and well tolerated. And ROCKET 2, which has completed the phase 3 trial, showed that it is statistically non-inferior to timolol if the pressure is less than 25 millimeters of mercury. Fixed combinations, as you can see, latanoprost plus natasidil provides statistically superior ocular hypertensive effects when compared to the individual components. And the mercury trials have compared and shown that once daily natasidil and latanoprost combination produce a very statistically significant reduction in the mean intraocular pressure. So apart from the IOP reduction. ROCK inhibitors have, especially the ripasudil, they are said to inhibit the differentiation of the tenon fibroblast to myofibroblast. So it is believed that post-trabeculectomy, you can prevent scarring with the use of ripasudil. So also in post-keratoplasty eyes, usually topical carbonic anhydrase inhibitors can further worsen the decompensation. On the other hand, this drug is safe, is found to be relatively safe in such eyes post-PK, post-DSEC, Fuchs, corneal dystrophy, etc. So it is, we have more or less used this as adjuvants in uveitic and steroid-induced glaucomas. And ripasudil is said to have also got neuroprotective role by increasing the ocular blood flow. Next, coming to latanoprostene bunod, which got US FDA approval in 2017 as a once daily medication. It was launched in Delhi also, and but then because of the high cost, it was launched by Bausch and Lomb, I think, and because of the high cost, it could not gain popularity, and we are all looking forward to its relaunch at an affordable cost. This is a molecule which has got two active metabolites, the latanoprost acid and the butanediol. The butanediol, which gets hydrolyzed to nitric oxide. And nitric oxide, as I told earlier, produces smooth muscle relaxation and improves the trabecular outflow. While the latanoprost acid, it acts on the FP receptors and improves the uveoscleral outflow. So it's got a dual mechanism of action, and thereby we can expect a lower reduction of intraocular pressure, as shown in the Voyager study, where LBN, that is the latanoprostene bunod once daily, was the lower one of the two, that is latanoprost and latano versus latanoprost 0.005%. The Constellation et al. Study has shown that when compared to timolol, the nocturnal IOP reduction is there with latanoprostene bunod, and also there is said to be an ocular perfusion improvement. The Apollo and the Lunar studies are RCTs of 3 months duration, which have shown that latanoprostene bunod is in no way inferior to timolol. While the Jupiter study is a 1-year study in Japan, which has shown that it is relatively safe. So patients who are on more than 2 anti-glaucoma medications, we have noted there's a significantly higher prevalence of ocular surface disease. So symptomatic ocular surface disease is known to occur in 48.4% of open-angle glaucomas who are on topical anti-glaucoma medications. So it is imperative we identify them. We all know that the BAK as well as the topical prostaglandins can affect the meibomian glands and affect the lipid layer of the tear film. Timolol acts on the lacrimal gland and affects the aqueous layer of the tear film. Timolol also acts on the conjunctival goblet cells. BAK also acts on the goblet cells, and they can affect the mucin layer. So what do we do to such patients? We can actually identify them, and we can use alternative preservatives. To the bad cases, use the preservative-free, and to the others, you can use the lower strengths of the BAK. There are drugs with strength as low as 0.001, or you can use the alternative preservatives like the SOC or Sofcia. Next, coming to the newer drug delivery system, Durista is approved. You got US approval, FDA approval in 2020. And here you have the drug bimatoprost, which is introduced intracameral with a disposable single injector. And there are trials which have, there are phase 3 trials have been done for this in this direction. They have shown that if 3 injections at 4 monthly intervals are given to the patients, there is no need for an additional drug for 1 year. But the concern is how good it is to the corneal endothelium. About 10% attrition of the corneal endothelium is noted with 10 microgram over 3 months, and about 20% with the 15 micrograms. Overall, there is an 82% reduction in the intraocular pressure with the 10 microgram. Next drug delivery system is the bimatoprost impregnated annular rings, which can be inserted into the palpebral fissure, into the superior inferior fornix of the conjunctiva. And they are polypropylene and silicone bimatoprost matrices of diameters of 24 to 29, which you can choose. Now, they're also only undergoing phase 3 trials, and they elute the drug with the concentration keeping on coming down for about 6 months. Occusert, pilocarpine occusert was there way back, but because of drug intolerance and not poor tolerability, it did not gain popularity. On similar lines, you have the punctal plugs. That is, you have these hydrogel plugs which have in them the prostaglandin analogs, travoprost, which has been marketed by which is called the OTX TP, which can be inserted into the upper and the lower punctum. And the drug elutes. The drug is, so there's a sustained release of the drug over a period of 3 months. It can produce foreign body sensation, epiphora, intolerance, etc. But definitely there are studies ongoing with comparability with timolol, and it is found to have more or less, it is not very much inferior to timolol. Contact lens impregnated anti-glaucoma medications and membranes or annular rings as reservoirs with the drug. All these are long-term, they're all being studied on animal models, and the long-term results are not known. So they are all mainly trials. So amongst the new arrivals that have discussed what are in clinical use now is the ripasudil, natasudil, latanoprost Bunod, and the Durista. What is undergoing the preclinical trials is the gene therapy, stem cell therapy, the short segment interference RNA, and the dietary alpha lipoic acid. Nanotechnology is fast evolving. Rings and travoprost plugs hopefully will hit the market. And you have the OMDI, the omidinipac isopropyl, which actually is marketed in the Japan. It is yet to get US FDA approval. Ginkgo biloba is used, vitamin A, vitamin C, there's not much of role. So to summarize, clinical care should be individualized. Rate of progression should be assessed for each patient. Only then you can plan your treatment intensity and targeted intraocular pressure. One should look into the affordability of the management option, the cost effectiveness of the option, and quality of life of the patient has to be kept in mind. Thank you all for your patient listening.